Somebody's keeping us on top of stuff.
It's always good. Hello and welcome to the Health, Occupations and Long-Term Care Subcommittee meeting. It's not our usual time, but we are really appreciative for those of you who are able to join us today on our Monday meeting of Crossover Week. We have 5 bills on the agenda today, so we're going to try and make as much progress on them as possible and vote them all if possible, if the committee is ready to vote on them. We're going to start with House Bill 1033, and then after that, we will hopefully do 1287 if Delegate Lewis is back from ENT, but if not, we will move on to 288 after that. So the first bill is 1033, which I believe is a Lisa bill.
Yep. House Bill 1033 requires the Office of Healthcare Quality during an annual inspection to monitor the compliance of each assisted living facility with the requirement to make available to all residents and employees educational and informational materials relating to immunizations for the influenza virus and pneumonia. The bill takes effect July 1st, 2021, and there are no amendments.
Excellent. And Delegate Cullison, do you have any stakeholders here, or do you have anything you want to add on this bill?
No, and everyone was on board. Everybody saw that it is a reasonable expectation of OHCQ, and we really want to beef up the administration of these vaccinations. So we're
move the bill.
Excellent. The bill has been moved. Does someone want a second?
Second.
Moved and seconded. Any further discussion of this bill? I don't see any hands popping up. I'm giving people a second. All in favor, say aye. Anyone who's opposed, go ahead and raise your hand in the side. I don't see anyone opposed to flu shots for senior citizens. Go team. Passes unanimously. I don't see Delegate Lewis is with us yet, so we'll take up her bill, even if she doesn't come back, but I want to give her the chance to talk about it if she does get here in time. So let's move on to 288, which is Delegate Charles's audiology compact. We discussed this last week, and there was a little bit of confusion around what the amendments should look like. So I know we've made significant progress since then. So as we let the stakeholders into the room, Tyler, do you want to give us an update on where we're at with this bill?
House Bill 288 has 2 amendments being offered from Delegate Charles. I would say predominantly they're both technical in nature. Amendment 256384 is on page 2 of the PDF packet that Lisa sent around this morning. This is from the result of work from representatives for otolaryngologists, ENTs, working with ASHA and MASHA to adjust the language slightly to help serve the otolaryngologists' interest in the compact. The second amendment, starting on page 4 of your packet, is purely technical, bringing just a couple small words in line with the compact language to more closely reflect it.
Excellent. And then Tyler, can we move both of these amendments at the same time, or do we need to do it separately?
I think that'd be fine.
Same time? Okay.
Mm-hmm.
I see Delegate Charles is here, and I see Dan Shattuck, it looks like, is here. Delegate Charles, anything you would need to add?
There's nothing that I need to add to it. We have the technical amendments, and we have the additional amendments. I believe everybody is on board based off conversations that I've had. So I'd say we move the amendments.
All right. Anyone want to second them?
Second.
Moved and seconded. Any further discussion on the amendments before we discuss the bill as amended? I'm not seeing any. I see the stakeholders all here. I don't see any of them jumping up and down, so I don't think we need to discuss the amendments. All in favor of the amendments, say aye.
Aye.
Anyone who's opposed, go ahead and raise your hand, but I don't see any hands up. Now, on the bill as amended, just want to
bill.
Moved. Anybody want to second it?
Second.
All right. So discussion. We don't have a lot of time. I'm seeing all stakeholders nodding or sitting there. So I think everyone's okay with this. Yes. Excellent. Any further discussion from the committee members on this compact bill? Okay, none. So all in favor of the bill as amended, say aye.
Aye.
Anyone who needs to oppose, raise your hand. Again, passes unanimously. Go team. Thank you very much. Thanks for working it out over the weekend and figuring out the amendments we needed. We appreciate it. What is next? I guess we can talk about, oh, we're making really good time, you guys. Let's
Yes.
and do Delegate Lewis's bill for her, even though she's not here. I think that was a pretty clear-cut bill too. That is a Lisa bill. So that's.
Oh, she's here.
Oh, she is here. Delegate Lewis, are you here now?
Hang on. She's coming in.
Coming in. Perfect. Perfect timing. And I see Ann Seacott is here, so I imagine we have some other stakeholders on this bill. Lisa, do you want to remind us what this bill does, and then we'll have a discussion on this bill?
Sure. House Bill 1287 expressly permits an individual to use telehealth when practicing clinical alcohol and drug counseling without a license or alcohol and drug counseling without certification if the individual is working as a trainee under supervision while fulfilling experiential or course of study requirements. And there were no amendments offered.
Excellent. And Delegate Lewis, are you here now?
I am. Thank you, Madam Chair. I'm here. I had a bill in subcommittee across the hall. Thank you so much.
No problem. I think we can be quick on your bill because I know you have multiple, we all have competing priorities. So Lisa explained the bill to us. I see Ann Seacott is here to answer any questions. Anything else you need to add about the bill? No. Do we have questions from the committee on this bill? I'm not seeing any hands up. So it sounds like everybody likes the bill. I see a thumbs up. So does anybody want to move the bill?
Move the
Actually,
bill.
Madam Chairman,
Is that
my
your hand?
thumbs up actually was supposed to be a hand.
All right. Go ahead. Ask your question, Delegate Saab.
So can you just, I'm sorry, I want to make sure that I understand this fully. So they can can you just really explain it real quick in 2 sentences? What would this bill do? I just want to make sure that I'm voting correctly on this.
Sure. Ann, do you want to go for that?
I'm happy to. This simply allows the clinicians who are certified by the Board of Professional Counselors as alcohol and drug trainees. It's already an established process. We're not changing that process. To be able to provide their services via telehealth, as telehealth is defined, however telehealth gets defined. It just removes a barrier for their participation. We are not changing scope of practice. We are not changing supervision requirements. We are not changing anything related to the criteria, standards, anything like that. We're just simply allowing them, like other clinicians, to be able to deliver services via telehealth. And they do make up about 40% of the workforce.
Okay, my concern was that the supervision, because that's what I thought was mentioned. But if it doesn't change anything, my question was asked. Thank you.
Great. Wonderful. Any more questions on this bill from members of the
I think I put my hand up, but it went down.
okay.
I just have a question, and I don't know if this impacts this at all or not, but I was just told this week that we've not done urine test and drug tests on our probationees since COVID's been in, and it's been a real problem. We've had a lot of recurrences because of that. Does this in any way inhibit or replace the ability to be able to do the drug or urinalysis test to make sure people are still on target?
No, I think that overall, as we see patients and clients returning to in-person clinic visits, that will increase again. But of course, at the very beginning of the pandemic, all of it basically shut down in terms of the in-person stuff. So this doesn't have anything to do with that. But we are expecting to see the urinalysis testing process tick up as clinics open back up, as all of us start going back to in-person healthcare.
Okay, because again, this is for parole and probation. These are state employees, and I was shocked to learn we haven't been doing it for a year, and we've had so many. I mean, that's their accountability. You can say whatever you want over the phone, but when you get that urine test, it's real accountability. So I want to make sure that we're not leaving that, because I think we've had a lot of relapses in the probation area because of not having that tool, and I'm not sure why they're not doing it, but I just heard about that. Thank you.
All right. So with that, I know the bill has been moved and seconded. All in favor of the bill, say aye. Aye. Anybody who's opposed, go ahead and raise your hand. I see no hands up, but we'll give people a second. Bill passes unanimously. Good job. Let's go ahead and move to 1040, which is also a bill that Lisa has been doing a lot of work on. Thank you, Lisa, for your help over the weekend with amendments, and to all the stakeholders. We'll let some folks into the room, but Lisa, do you want to give us an update on what the amendment looks like now?
Sure. So there's a reprint that starts on page 7 of your packet. Just so you know, there's a correction that needs to be made on page 8 of the packet. We're just going to be striking in lines 2 and 3, to an individual who is at least 3 years old. We're retaining all of current language in that section, and that was just inadvertently not struck earlier. So that will be in the final amendment. And then changes from last week are in the reporting language that's on page 10. And so the amendment now is requiring 2 different reports from the Prevention and Health Promotion Administration of the Maryland Department of Health. The first report is due by December 1st of 2021. And it's just kind of a basic report, though, that says how many vaccines have been administered under the bill and how many adverse reactions there have been, and any other information that the administration feels that the General Assembly needs to know. And then there will be a second report, the main report, due back on December 1st, 2022. And that report will evaluate data from Maryland and other states on all children vaccines and study the effectiveness of Immunet, including input from all healthcare providers that administer vaccines to children. The report will consider public health models in which pharmacists in both chain and independent pharmacies work in partnerships with local health departments, pediatric primary care providers, and schools. And the report will address implementation recommendations, including tracking multiple dose vaccines, optimal physical space configurations, and staffing requirements.
Awesome. I already have a hand up from Delegate Morgan. So before we go to questions, we have a lot of stakeholders here, and from Delegate Krebs as well. Before we go to questions, we have a lot of stakeholders here, so I'm sure they all have some thoughts on this amendment. I just want to make sure the committee really understands that the intent of the amendment is to do a model very similar to what we did with telehealth, sort of recognizing that this federal order is already in place, allowing pharmacists to administer vaccines to children. So while that is happening, make sure that we get the information we need from the Department of Health in terms of making recommendations for how we should move forward or not move forward or whatever in the future, since you have what is basically a big experiment going on the ground right now. Really make sure that we're getting the information we need from the Department of Health to make informed policy decisions in the future. So that's the intention of the amendment. And I know there's going to be some conversation probably of the timeline in the amendment. We wanted very much to have a similar timeline to what we did with telehealth, with the understanding that this federal order is in place, and that childhood COVID vaccinations, while older kids may be getting them in the fall, it'll really be 2022 before the 6 to 12-year-old population is approved. So I think it's a reasonable assumption that this federal order will continue into that year. So with that, let's hear, everybody I think can see the stakeholders who are here. I'm already getting hands raised, so let's hear from Delegate Morgan and then Delegate Krebs, and you can direct your question to any of the stakeholders who are here.
Actually, my question was for Lisa. Can you read that part over again where they're going to study? I think you said they're going to study the adverse effects in mind.
They're going to report back.
Yeah.
They're going to report back on how many vaccines have been administered under the, I guess from the time the bill is signed until December 1st, to give us an estimate of how many vaccines have been administered. And then it's they're going to report back on if there have been adverse reactions, which I believe the pharmacists are required to put in Immunet if there have been an adverse reaction.
And the vaccine that you're talking about is the COVID vaccine?
No, it's all childhood vaccines that
But
they're
you
allowed
get
to
adverse
administer.
effect if you're a child and you have an adverse effect. How would the pharmacist even know? Wouldn't you take the child to their pediatrician?
This is the pharmacist is administered the vaccine and right after they administer it, there's an adverse reaction.
So it would have to happen in the
Clinicians might know more
first
about
10
this.
minutes, like penicillin or something like that.
That's not a vaccine, I don't think.
Well, but I mean, when penicillin is normally administered, it's normally a time where they wait and listen. So it would have to be an adverse effect right then and there.
Right.
Correct.
So let me be clear, Delegate Morgan. I'm the one who requested that we do this interim report, and I was trying to find some space in between. You know, there was discussion last week about the timeline and whether it was appropriate. So I really wanted to give the members an opportunity to hear if there's any big red flags or any major concerns on the ground between now and next session, that we would have that opportunity to hear about it. That was the only intent of that language.
Gotcha. All right. Well, let's hear what everyone else has to say. Thank you.
Okay. Delegate Krebs.
Thank you. And maybe Pam might want to weigh in on this, but for the longer report on 2022, the one thing that I think we want to make sure of is that our in-person visits, our well baby visits or whatever, are still continuing, and this isn't replacing it. So I don't know if we have to put that language in there or if that's something Department of Health, but I think that's one of the main concerns, is making sure that kids are still showing up for well patient visits. And I think in the bill, it says that they're supposed to advise or recommend that they do their well patient visits, which is good, but we want to make sure they're increasing versus decreasing as we expand access to the vaccines. And the interim report, I think, is a good idea about, you know, just to get the breadth of how many people are taking advantage of these things just while we're moving forward. But I just want to thank you. I really think doing this study while we're under this state of emergency, and we're continuing to do this anyway, I think doing this study, it gives us information to make good decisions on whether we should continue it. And it gives everybody data. And again, it's just continuing. So I think we should just look at that study language and make sure we're capturing all the issues that we really want to make sure we're looking at. So I don't have it in front of me, the amendments, but just add that, and maybe Pam can see if there's anything else that the pediatricians want to make sure of about really accessing care, because we don't want this to be in place of care. We just want it to be easy accessibility we want to make sure we're increasing the immunization rate from what it is now, because we know it's gone down by like 50% over COVID, but we also want to make sure we're doing the well baby visits. So I think we can find a good balance.
Thank you. And then let's hear from, looks like Delegate Saab has his hand up again. Delegate Saab and then Delegate Kerr, and then we'll hear from Pam Casemeyer. And I think Jill McCormick had her hand up. So Delegate Saab.
Thank you, Madam Chairman. So in the study, it seems like it's going to be a very detailed study. Is MDH able to do the study? Have they weighed in as far as, is this something they can do with existing resources? And do they have to hire somebody else? Has anybody talked to them?
I think the language in the amendment specifies it should be with existing resources. I don't have it printed out in front of me, but I know one version of it had that. I think the premise of asking MDH to do this is that basically this is their job anyway, right? One would expect they're doing this anyway. So we're just making sure that it's getting done. We're not really expanding the scope of their work. The feds came in and they made this order and they changed how things work on the ground to make Maryland really different from how we have pursued these things in the past. So I think it's within the scope of MDH's existing work to answer these questions. It's not, although it's all it's a laundry list of questions that we all have had, and I thank all the members of the subcommittee for contributing to that. I don't think any of those are questions that, to the point Lisa was making before, we have the existing technology and information to pull this together, pretty easily, as long as we're paying attention to the work that we should be doing during this crisis.
And how long after, if I may, just quick follow-up question, how long after the executive or the emergency is over that they have to submit the report?
So Lisa, do you want to walk through the timeline again? We have the basic report coming the 21st, 2021, the final report coming the end of 2022, so that we could make policy decisions just at the same time frame that we're doing the telehealth decision, right? The session of 2023, we would make policy decisions about whether we want to continue this in part, not continue it at all, etc.
That's right. The second report would be December 1st, 2022.
Thank you. Thank you, Madam Chairman.
Absolutely. I see Delegate Kerr, and then I want to make sure the members get their questions in, but then we can go to the stakeholders. Delegate Kerr.
Thank you, Madam Chairman. We had spoken offline about specifically tracking whether this was first dose or second dose of these Is that covered under the tracking of multi-dose vaccines? Was that your intent?
Yeah, that was the intent, to include the conversation you and I had.
Okay, great. Thank you.
Absolutely. Okay, so let's hear from, we have Robin Elliott, Jill McCormick, and Pam Casemeyer, and any other stakeholders who want to weigh in, please do. Let's hear first from Robin. Oh, and Pat O'Connor, good.
Great. So Robin Elliott here on behalf of the Maryland Nurses Association. Just wanted to make a couple of observations. One is very much agree with Delegate Kelly that this type of work is under the purview of the health department. I do think they already have quite a bit of it, so it's pulling it together and doing some more structured discussions with some of the stakeholders here. The second is in response to Delegate Krebs's question. I think one of the things the department has is Medicaid claims data. So your question about looking at making sure that these vaccination visits aren't replacing well child visits, I think that is something that Medicaid can pull and help evaluate with. And I think that's a really important question. We've seen a similar question come up for when pharmacists began to prescribe contraception. And there was a study in Oregon that showed that it was additive rather than replacing services. So, but we don't know. We'll see when the data comes up.
Thank you. Oh, so many more hands. I can't remember who was next. I'm going to go with Pam Casemeyer because her hand's been up a while. Pam.
Hi, yes, thank you very much. And so just a couple of further comments on the study and a little response to what Robin had said. I would caution about relying too much on claims data and Medicaid because you've got to pull it from all the MCOs. It's not as easily to pull, but more importantly, we're not just talking about Medicaid patients. We're talking about private pay patients, and we're talking about uninsured patients. And quite frankly, the Medicaid doesn't make up or a majority of the children in the state. So it's a little bit of an indicator, but I would say it's I do want to, give her credit for making that suggestion because it is something the department could work on. But I do think there needs to be something more definitive written into the study that requires them to do some type of an analysis of well child visit reductions, because there is a bit of a difference between, or a lot of a difference between contraception issues and well child visits, because the parent controls that and the parent decides, did I get my child everything they needed? And many parents don't understand if they get their vaccines, what else is needed. And I appreciate what's been put into the study for looking at models to have that communication and stuff. It's just that the data collection itself, only counting the number of vaccines that were given and adverse reactions, doesn't really tell you the whole story. So the only other thing I would say is I think it would be good to check with Immunet folks in addition to the prevention and health promotion to make sure that this data can actually come out of Immunet. And the other thing you should know is there's a lot of missing data that people think they put into Immunet and then you can't get it. It even happened to me as an adult. I had a vaccine, my doctor went to get it. It wasn't in Immunet, it had been entered, it didn't show up. So I want to make sure that there's an understanding of the limitations or not of what this study may produce. Not that we're not agreeable with it. It's just don't want expectations that can't necessarily be played out. And then the last issue with respect to adverse reactions, just responding to what someone had asked. Adverse reactions often happen immediately thereafter, but there are adverse reactions that can happen over time. And so back to someone's question, I think, and then the one last issue is, this is a very technical issue, but when you talk later about frameworks for things like optimal space for privacy, it's not just privacy, it's safety. Because as you heard from a couple of the mothers who had kids that had passed out, fell off tables, it's not just privacy, it's safety. And it's also sometimes needing to keep the child there for a certain period of time to wait and see what happens. So the space part of that has to be safety as well as privacy. So that's a very technical issue, but it's not it's an important one.
So maybe we just take out privacy and we say optimal space. That's an easy tweak to make. I get your point.
Yeah, I would say privacy and safety because it is both.
I'm not opposed to that. That doesn't make any sense. I mean, it doesn't cause any problems for me. So maybe we can just add that tweak in. To the point that you were making, sorry, there were a couple and I was just taking notes, but just want to point out based on Delegate Krebs' question, I was looking for the language in here specifically that we added in that really clarifies, in very firm words, the pharmacist shall inform each child vaccination patient and adult caregiver who is accompanying the child of the importance of well child visits with a pediatric primary care provider and refer the patient to a pediatric primary care provider when appropriate. So we definitely made sure to write that language in there. And then also in terms of the percentage of well child visit reductions, the reason we didn't specify that really clearly the way you're asking for in this study is because we know that we are operating in a place where the data is not going to be reflective of long-term trends, right? We are at a place where vaccination rates are at an all-time low because of the COVID crisis. So we didn't want, that is something that we want to look at, but we will have better data 2 years from now and 3 years from now than we do this year on that because the vaccine rates are so low. So, there's been conversation of that and your point is well taken, but, this next 18-month period is not going to give us an accurate answer to that question.
Okay.
And in terms of Immunet, we could, I suppose, Lisa, maybe add in, there's catch-all language in that interim report that I would expect problems with Immunet be also included in that. But if we wanted to spell that out, I would be open to doing that too. I don't think that's too hard to add a couple words there so that we would know, at the interim report time, sort of any immediate changes or oversight or, challenges with Immunet that need to be addressed in the next year.
Delegate Kelly, and I appreciate what you said about the well child visits, but maybe if that catch-all phrase had something related to the impact on well child visits, then you don't have to specify like number or not. I'm a bit concerned even about the number of vaccines administered by pharmacists in a vacuum because you don't know the context for all of that. But that's beside the point. I do think you have to build that into the interim evaluation one way or the other.
Okay, so just sort of broad language on impact on well child visits in the interim. We're not trying to be too prescriptive because the Department of Health is very busy as we're getting out.
Understand.
So we can add in, as if the committee's okay with that, a general language in that space. Let's hear from Jill McCormick and then Pat O'Connor. Jill.
Hi, good afternoon, everyone. Jill with the National Association of Chain Drugstores. I want to thank Delegate Kelly for putting together this amendment, help leading on this amendment to come to a consensus on this bill that we've been working on for a number of years. But I also just want the committee to be cognizant. I agree with Pam Casemeyer in a lot of areas here. The data that we're asking for, especially in the first study, it's in a vacuum. And, for example, adverse reactions, which are very rare, especially serious ones are very rare, but adverse reactions can range from your arm being sore and a little redness at the injection site, which I got with both the flu vaccine and the COVID vaccine. And basically everyone that I'm hearing from getting the COVID vaccine is getting really sore arms.
Right.
So there's a difference between having a sore arm and, something serious happening. So, when we're reporting on adverse reactions, that could be a range, and the range could mean many different things. Secondly, adverse reactions follow the patient, not the setting where the patient gets the vaccine. So a patient is no more likely to have adverse reaction in a pharmacy as they are to have an adverse reaction at the doctor's office or some other healthcare setting. So if you're going to only look at adverse reactions that happen in the pharmacy, you have to compare them to something else, right? You can't. So, I mean, my suggestion would be the number of serious adverse reactions, maybe adding the word serious there, experienced by children administered vaccines by any immunizer. You know, and short of that, you just have to understand that if this comes back with, you know, 2 adverse reactions or 15 in a year, if you're not comparing them to all the adverse reactions that are happening, it's not going to be necessary useful information.
That's actually really interesting, and I would like to hear from the committee because it looks like we're going to make some tweaks to this amendment. And again, I explained to Delegate Morgan's question the intent of the interim report, but maybe the language around the interim report isn't exactly what we need, and we should combine what we're hearing from Ms. Casemeyer and Ms. McCormick and really just, you know, narrow down that language around the interim report and focus on point 3, which is at the interim report, they should be giving us any information that the administration determines is important for setting policies for administering vaccines for children, right? And that could include impact on well-child visits. It could include these privacy and safety issues. It could include issues around adverse reactions if that's an issue, but we do not want to be charging them with a study. Obviously, this is also part of their job, but not part of this bill, you know, on adverse reactions in general to vaccines that, you know, I don't want to get too big. So maybe we actually narrow it. And I wonder how the committee would feel about that.
I think being, Madam Chair, if I may, I think being more prescriptive, no pun intended, would be a good thing here. Adverse reactions are, there's a whole body of requirements around adverse reaction reporting at the federal level. At the state level, we don't want to be duplicative. We don't want to burden, you know, these providers. So more specific is probably better. So
it sounds like then in more specific, the report that we would be directing, that we would be requesting would be just the department should tell us anything they think we need to know.
Right.
Right. So that we have blanket language so that we're basically saying, if you have red flags, we want to know. And whether it's because of a decrease in well-child visits or an increase in adverse reactions or an increase in vaccination that is really great that we're excited about, we just want to know from the department something.
Exactly. Yes.
And the two things that we're trying to make sure is that we increase immunization rates in a safe manner, and that we either increase or remain steady well-child visits. I mean, hopefully increase. So that's the 2 goals. So whatever information we need to do both of those things is will be applicable.
Excellent. I have Delegate Collison's hand up, and then we'll go to Pat O'Connor. Delegate Collison.
Well, just quickly, but I think we've moved beyond it. In terms of designating the adverse reaction as serious or not, I think that's a little bit, it's too broad. I'd rather see some sort of, if we're being prescriptive, what was the reaction, or is there, are there different levels that are already defined someplace that refer to the kind of adverse reaction that someone had?
And my hope would be that final report is getting into that level of detail, but we don't want the department to be distracted with that for the interim report unless they're seeing red flags.
Yeah, got it. Thank you.
Okay, Pat O'Connor.
Thank you, Chair Kelly. The temporary emergency order is based on a risk-benefit analysis that took into account the pandemic circumstances. And it seems logically that as those circumstances fade away and as the pandemic ends, the license or permission for pharmacists to administer this broad range of vaccinations likewise should end. And we should have a clear demarcation point when all the pandemic data can be collected. So either we go, I'm just trying to understand why June 2023 rather than synchronizing it to the end of 2022, because that will stop the practice at a point in time when the circumstances justifying this will have passed. We already have pediatrician offices open, and they will have been open for a long time by the end of December 2022. So we would ask for that change. We remain concerned about the risk to children receiving these vaccines in a pharmacy setting rather than in an office or clinic setting. We know that adverse reactions that are serious occur. We just don't know who they will happen to or when. And that underscores the importance of the where, because we want to have trained personnel available to protect the child or children involved. So we would ask for terms that would protect patients under these circumstances. A third point is the pharmacy board, we believe, is an important resource in any study that would occur. As we understand it, the pharmacy board is very familiar with Immunet and its defects and deficiencies. And they would also receive complaints about pharmacists during this period when this is being allowed. We've gotten some complaints. We refer them to the board. We would ask respectfully that there be an express requirement that all complaint information relating to this be included and analyzed. Another important point is that consumers are not included in the list of stakeholders that will participate in the work group or the study. And we think their participation is essential. We just hope moving forward that we feel like the parents' testimony deserves a lot of weight, and we would ask the subcommittee to do all that is possible to limit the risk to children and to mitigate those risks as much as possible. Thank you.
Okay, so I think in taking notes from what you were saying, specifically adding to the amendment consultation with the pharmacy board and specifically adding a consumer, I'm looking for where we want to add that in to the amendment.
Well, so on page, if I may direct you to the last page, subpart 2, shall consult with interested stakeholders, including providers, pharmacists, managed care.
So right after
organizations.
local health departments, we can add the Board of Pharmacy and consumers.
Well, so certainly add consumers there, please. Okay. And the Board of Pharmacy, we believe, warrants participation, perhaps even at the level of PHPA at the MDH. So in subpart A,
The administration could consult with them in the study.
Yeah,
it's already in there, but we can add consumers.
No, it could. I'm saying we can add that.
Yes. We think that could be valuable because of the Immunet issues, which are potentially so problematic. And we also would want all of their complaint data and complaint data from any agency to be collected and analyzed.
Let's hear from Delegate Bandari. He has a question.
Yeah, thank you. Thank you, Madam Chair. Really listening to the bill, the major concern, the privacy, safety, and adverse reaction. And according to Pam, and I'm glad that we made a lot of progress, what we study and under what circumstances that has been addressed, I believe. And still, I think we are debating on the adverse reaction. I'm wondering, like, can a pharmacist notify the child doctors, or what type the internal effective communication is there if anything happens, So
let's hear from Aaliyah, because she had her hand up anyway. So I know she had some comments to make. So Aaliyah, can you walk us through from a pharmacy perspective, sort of what the process is now that this is already happening on the ground?
Thank you.
Was not prepared to answer that specific question.
I'm sorry. Is there someone else
maybe defer
who can probably Jill McCormick can answer, would be my guess.
Hi, so the current process, so right now we are required by law to both, in many cases, do a personal notification to the physician if the patient has a physician. So that's usually a fax or an electronic form that gets sent to the doctor's office, stating that we've given the patient a immunization. And then secondly, we're required to report to Immunet. So there are 2 notification systems already out there that we're already using. if that answers your question. If it doesn't, you want to restate it, I'd be happy to.
I think
Try
it
again.
answers the question. We have notification systems that exist right now, but the report is asking specifically for the Department of Health to make further recommendations if we need to strengthen those policies or change them or tweak them. The purpose of this report would be to use the information we're gathering right now while this is happening to have the department make recommendations to those questions, Delegate Bhandari.
Madam Chairman, if I can.
Yes, please.
So Pam, so you were talking about the permanent framework and adverse reaction, and does that answer your question? It seems that there is already a system in place. If anything happens, they can notify. Does that solve the problem of adverse reaction in case if there is one?
The Immunet process itself is not adequate enough related to adverse reactions because of the complexity of it. And you also have the question of the level of adverse reaction and whether or not there is any communication directly. Reporting that an immunization is given is not the same as making sure there was a clear understanding on significant adverse reactions. So we're not comfortable at the moment that that framework exists. I mean, in fairness, we appreciate all that Delegate Kelly's doing. We would echo some of what Pat O'Connor said about shortening the dates. We understand this is done under the framework that we use for telehealth, which keep everything current while you study it, and then it sunsets. We would have preferred to see this stays in effect till the end of the emergency, but then sunsets even as we study it. And maybe we'll come up with recommendations, because a number of the recommendations of things that is supposed to be looked at on the long term have very significant health issues, like safe space and ability to respond and those kinds of issues, that tracking multi-dose vaccines, that we don't really know how well it's working now. We just don't have any other options. But that being said, I think the adverse reaction communication to the primary care provider or to someone is going to be important.
So Pam, can I
Because
stop you for a second? In the final report, the report shall make recommendations on, should we add a line in on there that says, any recommendations for strengthening communications on adverse reactions or the need to, or, is there language in there that we should be putting in so that we're sure we're getting the information we need? Oh, you're on mute, Pam.
the stronger you can make the overall communication efforts, the better, especially given this population, because you have to remember, this is down to age 3. This is not now 3 and 4, maybe you're going to have someone with them, but you've got some pretty young kids, and even adolescents, where now you're not going to have a prescription requirement for adolescents. So adolescents could theoretically come on their own. There's adverse issues, there's no reporting.
So the final report is going to evaluate the data, right? It's going to study the efficacy and the effectiveness of Immunet, including healthcare providers, et cetera. And then it should also consider the public health models in which pharmacists support and facilitate families in obtaining well child visits. So, we're specifically talking about that and partnering with local health departments and school-based health centers and those things. But do we want to add, in addition to the report shall address implementation recommendations, including tracking multi-dose vaccines, optimal physical space, and then we're going to add that word there for safety, and then staffing requirements. Do we want to add something under there that specifically says processes for dealing with adverse reactions?
Yeah, that's probably a good idea.
Okay. Awesome. Thank you, Delegate Bhandari, for your great question. Really appreciate it. Delegate Riley.
Thank you, Madam Chair. Yeah, actually, I had a couple questions. I believe actually Pat O'Connor, and between what Pam Casemeyer has said, pretty much answered my questions. So I just think that we're trying to push something through because we're against a time frame. And I don't think that's necessarily good policy. And I would have liked to seen, a sunset on there. So I guess
Well, it does have a sunset. It has
Okay,
a
so
very
it does-
fixed sunset on
Okay.
in 20.
And
So
December-
if we do nothing,
December 1st, 2022, is that the
no,
sunset?
the sunset is June 30th, 2023. So we will get the
2023.
report so that
Okay.
so that we can see the report and make policy decisions. And if we make no decision, the whole thing goes away, right, in June. But if we make a decision, it could be that it's, we are allowing this under narrow circumstances and only if X, Y, and Z are met. We will then have the information we need to make the decision if we choose to not let it sunset, whether we want to narrow it or not. There's I agree that maybe going down to 3 might not be appropriate. We're not, we will have the ability to make those choices or the ability to let it sunset. But
Okay,
the reason we have the timeline the way we do is because we wanted to be the ones who were in charge of making the decision after we received the report and were able to make those smart policy choices.
Okay, so the sunset's definitely not at the time frame of when the pandemic ends.
Well, we don't know when the pandemic ends, so
Correct.
we didn't write language that that said, 3 months after the president removes this, because we don't know if we're going to be in session then or not, right? So the default is it's definitely going to stop. It's definitely going to stop June of 2023 unless we act.
Okay, all right, thank you.
Absolutely. I think Aaliyah was next.
Yeah, I was just, I got stuck on the compilation of complaints just from pharmacists. And I was just thinking that every healthcare provider gets complaints. And so the collection of complaints is to what end? Yes, we can understand what the context is, but I do think it needs to be compared because we're adding on a service that other healthcare providers are doing. And so it should be, I don't know if it's the rates compared or something, but it should be within a context, not just, okay, you got a collection of complaints and we're going to base a decision on that, when you could do the same thing for every other healthcare provider. So I kind of got stuck on that. That's why I wasn't able to answer the other question. I was still wanted to make sure I could follow my train of thought.
Yeah, it sounds like the language that we're talking about is going to be really broad and encompassing the larger conversation. Let's hear from Rob and Elliot.
Just wanted to raise some thoughts about the sunset date. One of the reasons why the nurses are supporting is access in rural areas. And I think that what we want to be careful about is not end programs or policies too abruptly. I don't think the consumer, most consumers understand when a federal public health emergency order is in effect or not. So to have some easing of transition there, I think is important. And so we're not looking at cutting off access abruptly. The other thing I'll just note is that date, June, I think a lot of vaccinations happen in the summer because they're related to going to school. So that would leave, I think, most of the vaccination rush for 2024, beginning in the 2023-2024 school year, would it's still open whether or not that would be pharmacists and the primary care providers. So those are the two observations about that date.
Thank you for that. We're going to hear from Pat O'Connor, Kaylee Locklear, Jill McCormick, and anyone else who raises their hand now. Otherwise, I think we need to move on. So Pat.
Thank you, Chair Kelly. We would prefer that this statute not be changed and that the order simply expire, and that a comprehensive study like the one being discussed be ordered. As I've listened to the 2 points, the language about studying the safe premises and safe administration, putting it there in that way and making it sound future looking sort of invites the pharmacies to believe that they don't need to take that care now to ensure that children during this period are receiving the vaccines in the same way physically with the same physical protections as are present in a provider's office. And we think that's what the consumer testimony focused on, that if an adverse reaction happens in a provider's office, the child is positioned properly, the personnel are available to assist with the emergency. All of those built-in structural safeguards when vaccines are delivered in a provider's office are missing in the pharmacy as we understand it now. And we're not including an express requirement that basically says, hey, for the remainder of the time that you're doing it in Maryland, we want you to provide these safeguards. Those are not spelled out in the temporary federal emergency order, but we believe this is an opportunity to spell that out now. And
But
we
hold
would,
on. So do you have language that you're suggesting we put into this amendment in the first section?
I will come up with that language, because as I've been listening to these forward-looking recommendations, I believe there is a very real risk that suggests there's not a current obligation when this under the standard of care there is.
I don't think that the intent of this amendment is in any way to suggest that there's not any current standards or requirements. I don't think that by putting this amendment on, we're changing that reality in any way. But I guess we can ask Jill McCormick, who has her hand up. Is that how the pharmacists would interpret this?
If I can jump in.
Haley, sure.
I would love to jump in here. I'm sorry that we keep going in circles about this. The language that we've explicitly put in the bill on page 9 around training is as specific as we're going to get here. So at the federal and state level, both physicians as well as pharmacists are receiving the exact same training, the same general best practices and guidelines from the Advisory Committee on Immunization Practices. And so now I want to be very clear about what we're talking about when we talk about an adverse reaction. They're classified in 3 ways: local, systemic, or allergic. Local reactions, i.e. redness, are the least severe. They are very common. Those of you that have had the COVID vaccine, you know this. The second, some type of systemic reaction is going to occur less frequently than local reactions. Severe allergic reactions, such as anaphylactic shock, it doesn't matter what the medical setting is or what you have in that medical setting, you're going to have to administer an EpiPen and call 911. It does not matter whether you're in a pharmacist setting or a physician setting. And then the final type of reaction is allergic, i.e. an egg allergy is what tends to happen, and what either a doctor or a pharmacist will identify before administering those immunizations. So I just really wanted to talk a little bit more about that for the group. I can answer some questions there too.
If I could just jump in as well, I just want to say that a lot of the issues that are being brought up by the Attorney General's office and Ms. Casemeyer are already in regulation in the pharmacy. I mean, they're already in the Florida pharmacy regulations. We have to, make accounts for privacy because of HIPAA. We have to have the space to do this. These are all in regulation. We have to report adverse reactions, as do all providers to the national database, which is VAERS. Okay. And we would not, I just want to say again, the Pharmacy Act, we already have been doing immunizations in Maryland for a really long time, and also to children, not just to adults. So these safety processes are in place and are in either reg or the protocols. So some of these things we keep going in circles about, as Haley said, have already been taken care of and pharmacists have already been doing for years. Lastly, we would not, we need to have, by statute and by rule, a parent's consent to give a child a vaccine. That includes adolescents. So we're not giving anybody a vaccine without their parent being there and parental consent if they are under the age of 18. Just want to make that clear. Again, this process has been in place in Maryland and other states for a really long time, but it almost seems like some of these concerns are assumed that there's no protections in place right now. They're there. Thank you.
Thank you for that. Let's hear from Delegate Bagnall, then Delegate Cullison. Delegate Bagnall.
Thank you, Madam Chair. And I'm just trying to sort of bring the conversation back because I think
if I'm understanding the intent of the bill as amended, that this is about studying what we're already doing
Yes.
under the emergency order to make recommendations as to how we go forward. Because I think our conversation is starting to get a little muddy where we're actually trying to put the recommendations that we think are appropriate into a bill to identify recommendations for future policy. And if I'm also understanding the pharmacists, a lot of this already falls under regs and scope of practice and best practices. So we don't need to be prescriptive in a bill that is for a study of how, of next steps. Am I getting this right?
I would say that's a really great description. Yes, Delegate Bagnall.
Okay, thank you. I just wanted to bring the conversation back because I think I was losing the thread a little bit. And especially when we were talking about adverse reactions in the pharmacy as opposed to after the fact, which could occur in any venue in which a vaccine was administered. So I just want to make sure that I understood what we were talking about.
I appreciate it. And I think, sorry, my brain just lost what it was going to say as well. The intent of this study is exactly to recognize that stakeholders have very strong feelings about this, and we don't want to rush into making permanent policy decisions. We do need to take the time to do the study and figure out what's going on. So that's the purpose of this, recognizing that this conversation may have been sidetracked a little bit because people feel very strongly about this. Delegate Cullison.
Madam Chair.
Yes.
After hearing Delegate Bagnall and you complimenting, and that's PLE, her statement, I think it's time to move this amendment.
Second.
All right, moved and seconded. And let me just repeat that we're going to tweak the amendment to streamline the interim report with the language we discussed. We're going to add in consultation with the pharmacy board. We're going to specifically add a consumer, and we're going to add under the recommendations section a process for handling adverse reactions that happen in pharmacies. So those are the tweaks we'll make to the amendment. It's been moved and seconded. Discussion from the committee. Anybody? It looks like Delegate Krebs. You're on mute, Delegate Krebs.
Pat mentioned, studying it, shutting it down and then studying it. It's so, to me, it's like, I don't know how you study something when you're not doing it. And right now, it is a perfect opportunity because it's already happening. So, and the fact that this federal government might extend this, I mean, it's a great opportunity to do this while we have to do it. Because I don't know how you study something that's not happening. So we're killing two birds with one stone. We're getting the information. We're trying to target it so we can make good decisions when this is lifted. So I really think you've come to a good compromise, and I appreciate Kaylee and others explaining what we're doing currently. We're not just willy-nilly sticking shots in people's arms when they show up at pharmacies. We're trying to get kids inoculated, and the inoculation rate's shocking to me. I mean, 50% of people this year have not gotten their kids inoculated. And that's scary.
Thank you. Delegate Saab.
Thank you, Madam Chairman. I guess the more I listen to this bill, the less I like it. I do appreciate.
Is this on the bill or on the amendment?
No, on the amendment. Well, I mean the amendment which became the bill. I still have concerns because I know, you talk about training. They don't have the same training. When you talk about allergic reaction or adverse reaction.
In vaccine administration, they actually do have the identical training. That's what I have been told, and I'm seeing Aaliyah.
Well, they can have the training, but they don't have the history of the child. They don't have their charts. They don't know what's going on in that child's medical history for them to administer. So I guess study is good, but I think it needs to study not just the training part, but also the tools. If you want to have pharmacists administer vaccination or whatever they're going to administer, they have to have a full history of that child. I mean, allergic reactions can be catastrophic. They can be, you can have seizures, you can have,
But so delegate, do you have specific question you're trying to put into the study? Because otherwise this conversation we can have in sessions when we have the study before us, what the right policy choice is.
Well, I mean, I think in the study, it should specifically discuss the number one, I think the system has to be perfect. I mean, it is not. But also, what I would like to see is a little bit more history of the patient's medical, somehow, studied. And giving the tools, the same tools that the pediatrician has, to the pharmacist. I don't know how you put that in a study, but I think it should identify if the pharmacists have full access to the patient's history.
Right. And so the challenge is, of course, we also have kids who unfortunately don't have primary care. So there's that issue, but also there's the issue of, sorry, there's so much going on. I'm being hit in multiple different directions here. This is a study. So we're going to be studying Immunet. We're going to find out what the challenges are. We're asking the department to ask those questions that you're asking right now and to make recommendations for us, right? We're not making a policy choice. The federal government made the policy choice that right now this needs to be happening. We're just doing a study, making sure we're asking the right questions right now since this is happening. Let's hear from Delegate Bandari.
Yeah, thank you. I really like the bill. The reason is the accessibility, and I did research. Pharmacists are well trained on the vaccination, and as an educator, a lot of international student and a lot of out of student, they can't go to school on time because they don't have a primary care physician and they have to wait a month. I've seen 3 months missing schools. So I believe this is a great bill. We need to absolutely improve. There is no question. So I really like the bill, and I would like to move the bill.
Okay, so let's vote on the amendment first, and then we'll vote on the bill as amended. Thank you. And just, if you don't want to vote for the amendment or you don't want to vote for the bill, that's fine. We'll definitely count hands that are in the side. So on the amendments, I think we've discussed them. They've been moved and seconded. Any member who has their hand up is going to be noted as voting against them. So keep that in mind. All in favor of the amendment, say aye. And anybody who wants to vote against the amendments, please raise your hand in the side. Delegate Krebs, is that your intention? I'm pretty sure it's
No,
not.
she seconded. I don't think she voted
Okay,
against it.
so the amendments passed unanimously. On the bill as amended, it has been moved, and I think I heard someone second it.
Second.
Yes, moved and seconded. Do we need any further discussion on the bill as amended? I'm seeing, it looks like Delegate Riley and then Delegate Morgan. Go ahead, Delegate Riley.
You're on mute, Teresa.
Thanks, Matt. So you had mentioned that there's going to be more amendments coming. So are we voting on this bill as amended without those?
No, we are voting on the amendments in concept, which are those 5 changes that we got from Pam Casemeyer and Pat O'Connor. So I can repeat.
Okay, the ones that she spoke about. Okay.
Yeah.
Thank
So
you.
streamlining the interim report, adding in consultation with the pharmacy board, adding a consumer, and specifying in the recommendations that we'll be getting that we need information on the process for adverse reactions in pharmacies.
So you are saying that you are adding those amendments, and that's what we're voting on currently.
Right. So Lisa will put that into the reprint version that we have, but in concept, those are the changes that Lisa.
Okay, just wanted to clarify that. Thank you.
Absolutely. Delegate Morgan.
Yeah, I think we're going to have a philosophical difference on this bill because I'm old enough to remember when we're telling parents that they needed to take their children for well visits to the doctors. I mean, the reason why this is coming about is the crisis because of the pandemic. We made some exceptions so kids could get vaccinated at pharmacies. Now, I mean, someone just quoted a statistic that 50% of children are late getting vaccinated. Well, to me, that's more of a reason for them to go to the doctor. They probably haven't been to a doctor in probably a year and a half. And right now, today, every doctor has been vaccinated. All the first line medical staff has been vaccinated. So I think the message to parents is to take your kid to the doctor if he needs a checkup if you haven't been, not a study on how pharmacies work and whether this can be beneficial in the future. I'm going to be against the bill.
And that's, Delegate Morgan, philosophical differences are definitely allowed by all means. I do want to point out the language in the study. The study has been crafted in such a way that we're asking MDH to make recommendations, particularly with, helping us come up with tools that we can use to increase well-child visits. So I just want to draw that to everyone's attention. It says the report shall consider public health models in which pharmacists in both chain and independent pharmacies can support and facilitate families in obtaining well-child visits from pediatric primary care providers. And it talks specifically about building partnerships with those local health departments that are also doing vaccines right now with primary care providers, private practices, community health centers, school systems, including school-based health centers, et cetera. So, you know, the intent of the committee, I would hope, even if this bill passes, is to get a study and get recommendations from MDH that help us. I think one of the other members said this, you know, increase vaccination rates and also increase well-child visits. So it's two-tier goal, not meant to undermine it.
Well, the committee's done a great job, and you've done a great job, you know, getting this straight. So I would never speak ill will of your intentions. So you're doing
Thank
good.
you. And philosophical disagreements are always allowed. So I think we've heard from Delegate Morgan. Delegate Saab, did you have something else to add, or is your hand just up?
No, I do. So, I mean, I try to put the philosophical differences in this particular bill and look at it from a different lens. I guess my only concern is, and I do believe that Pat O'Connor brought up some great questions and concerns, and I know it's going to be addressed, but I don't know if, and I'm not trying to slow anything down or play any games, but I'm just trying to figure out, what if the language that's proposed in the, I know we're voting on it in concept, but what if the language is not good enough? Can we wait for the amendment to see what the amendments look like, and everybody isn't, you know, agreeing on the liability issue on
Wait, I don't think there's a liability issue. I'm happy. I hear where you're going. I just really need some specific direction in what actual issue we're talking about.
Well, I guess the question will be for Pat O'Connor, if she thinks that she can come up with language that addresses all her concerns. The same thing with Pam.
I don't think that we're going to get, you know, I think we've done everything we can for Pam, everything that she's asked for. From Pat, I'm not sure. I think her concerns are related to what MDH's recommendations might be, and that she really wants to make. I don't want to speak for her. I know she's here, but what I'm hearing from her concerns are not concerns to be addressed in the study so much as concerns to be addressed in the recommendation, with the exception of the timeline question, which is where there really seems to be some disagreement. I believe that the timeline is appropriate if you're thinking about, you know, us as the body making the policy decisions, that this is an appropriate timeline to do this study. I think that Pat O'Connor disagrees and would rather we not have a study that has taken place. I'm not really, I can't speak to her on that, but I know that the challenge is the timeline. And I think that I'll reiterate that the decision about the timeline was made based on an understanding of what the federal order looks like on the ground now, an understanding that we want to gather information during that time, because the practice is already taking place and we need that information to make informed policy decisions. And that session is January through April. So our expectation would be that policy decision would be made between January and April, you know, with a June sunset, should we not make a policy decision. So that, I can just tell you that's the logic behind the timeline. There's not, if there were compromise to be found, I would be looking for it, but I'm not, you know, I think that it's just a policy call that the committee needs to make as to whether we want to move forward with doing a study during this period, and give, you know, to the point that Robin Elliott made, you know, give the opportunity to increase those childhood vaccinations to the kids as they go back to school in the fall and things like that. So again, you know, philosophical differences are allowed, but I wouldn't, you know, if I thought that there were space, you know, to work on this, but Pat O'Connor's had this amendment for a couple of days. You know, I didn't see any language come to us. I know that the intention is to just not have the part of the bill in there that allows us to do the study, which is the part that says, you know, we're going to have this in place in Maryland while we conduct the study.
Well, no, yeah, I understand that. It's just hard to do the study when you don't have all the proper tools, but thank you.
Absolutely. I see Delegate Bandari and Delegate Bagnall.
Thank you, Madam Chair. Yeah, I really like the Delegate Morgan concern there, but I would like to clarify. Sometimes they have their doctor properly in their home country. When they come back, they have the immunization and everything, but you know, our school doesn't understand what's going on there. You know, so they still ask, go to local doctors and stuff like that. If they are coming out of the state as well, sometimes it happens. So this is the real issues that my constituents face as well. And in the meantime, if there is a privacy, safety, adverse reaction is included in the bill, this is just a study. I don't think we have to worry, and we can come with another bill that how they can communicate better, these pharmacists with their doctor, and then this card will be there, and World Child Visit will be there as well. I think this is a good bill, and thank you, Delegate Kelly.
Thank you. And before we hear from Delegate Bagnall and Delegate Krebs, I just want to add also the other note I had to make on Delegate Saab's point. Again, this is the timeline question. I really struggled with this because I want to do what's right for all of the stakeholders. And that's the reason I put in that interim report. So we will have another bite at this apple next session. If things are going badly, we will have that information in front of us and we can make a decision then as we know more about where the COVID situation is at that point. Delegate Bagnall, followed by Delegate Krebs.
Thank you, Madam Chair, and thank you for all your work on this and to all the stakeholders. I just wanted to mention that I view this bill as very much an opportunity. In Anne Arundel County, we have a very active crisis intervention team, and one of the things they say to us is that there's no wrong entry point for getting behavioral health services. That anywhere is an access point, and I feel like this bill might actually provide us information on how we can use our pharmacies as an access point for those well child visits, for getting them aligned with a pediatrician. Because even in the early testimony, we heard that Maryland was at 90% of vaccinations before COVID, but there's still that 10% population who, for whatever reason, aren't getting their vaccinations. And part of that reason may be that they don't have a primary care physician, they don't have a pediatrician. And so to me, this looks like an opportunity to figure out how to use pharmacies as an access point and take those recommendations from the Department of Health and hopefully turn our health crisis into something positive if we can utilize the information as needed. So I appreciate the way that you have amended the bill to give us that data. Thank you.
Thank you, Delegate Krebs.
Yeah, I think this federal state of emergency has given us opportunities in many ways to try things. And I'm just going to go from my perspective. I'm a parent that never missed a well child visit ever. However, when you send your kids back to school or whatever, sometimes your well child visit doesn't align with your immunizations that you need for school. So any of us who remember parenting, and the guys, I'm sure they didn't take their kids to their well child visits, the parent mothers did, but it's very hard sometimes to get appointments. In the summertime, all summer, you wait months and months, you can't get an appointment. And as a parent, I would have liked the option, the option, again, this is people's choice to be able to go and get an immunization, not in their pediatric office, but in a clinic or somewhere with somebody that is trained at the convenience that you can get an appointment. And it's also about access to these immunizations. We're finding during this COVID situation that people are not getting their immunizations. Doctors' offices were closed. People were hesitant to go. I don't know their reasons. So there's many, and the state of emergency can keep in mind, it's continuing now. This is still happening now. It's going to probably happen for the next year. We don't know how long the federal government's going to allow this to continue. It could be another year, it could be till the end of our study. So we're just taking the opportunity right now to study stuff while it's still happening. We have no control over that. Now they could stop the state of emergency next year, and then we could come back and say, hey, we're going to stop the immunizations. But I think while this is happening, it's a very good opportunity to see if this access to care issue, for many, many reasons, there's 20 million different reasons about access to care. Is it a good thing or not? And I think you guys have crafted this and to study it, not just say, let's just go do it, because we don't know. And our committee is doing that with a lot of things. And I've always said, we pass bills and then we never look back. And I think our committee is trying to do things and take advantage of these opportunities and look at what we're doing. And I wish the rest of the legislature would follow our lead and looking back on things and actually, are they good or not? So I think you've reached a good balance. And it gives it's again, a lot of the things that people have said about kids going in and getting immunizations at the age of 11, they can't do that. Their parent has to sign off. The parent has to say yes. They have to give comfort. And I would never even support this for a minute if that wasn't part of the law. And it is, they have, under the age of 18, your parent has to be there and you have to get permission. So I think it's a good bill.
Thank you very much. Any other members of the committee with anything to say before we call the vote on this one? I don't see any more hands up. So I'm going to say all in favor, say aye. And those of you who want to be noted in opposition, go ahead and raise your hand in the side if you want to vote against the bill. I see Delegate Morgan. I'm waiting to see if there's any other hands up as a no. It looks like I think Delegate Krebs's hand means to be down. She just gave a nice remark in favor of it. So Delegate Morgan and Delegate Riley are going to be no votes on this one. Okay, so it passes with majority support, but 2 no votes. And with that, we're going to move on to our last bill. I'm sure that people have another meeting scheduled. We're running over. Sorry.
Madam Chair, may I ask if can we possibly hold the bill? Only because I think there's some changes made and we don't have time and we've got another meeting and I think it deserves some, is that a problem to hold it?
You want to hold, so the bill we just voted on to.
No, the one we're coming up. We finished the other one.
So yes, and I hear what you're saying because people probably only booked an hour for this and this is a complicated discussion, right? So those folks who can stay on, let's have the beginning of the conversation, but recognize we're going to come back to this at the next meeting. Does that sound good? I don't know who.
Madam Chair, may I ask if can we possibly hold the bill?
Oh, we're echoing now. I don't know how many members are able to stay. I know a lot of folks have a 2 o'clock meeting. So I hate, this bill's been on our agenda for 2 weeks, but we can take it up first in our next meeting. I know that it's going to be a serious discussion, so I don't think, I'm looking at nods, so it seems to me like most members of the subcommittee have other places they need to be this hour.
No, I can stay. Nodding means I can stay.
Okay, so here's
I can stay.
We are not going to vote on this. We will discuss it so that we move the process along, but we will make sure to include folks who have to leave for another meeting. So it's a kind of a half hold, Delegate Krebs. We won't vote. We'll catch you up on any conversations. Okay. Does that sound good?
Yeah, I just can't. I mean, I got some concerns.
I know everyone's schedules are like this. So we'll begin the conversation. We'll discuss the 2 different amendments, and you'll be able to watch the video of this later so that you're up to speed by the time we vote on it at the next meeting.
Okay.
Sound good?
All right.
Okay.
Thank you.
Okay, super. So this bill, this is a Lisa bill too, House Bill 652. We heard it a while ago, and I know there's 2 different, Delegate Chi is here. Great. Hi, Delegate Chi.
Hi.
Sorry, our subcommittee is running so long. You can blame me. It was my bill.
That was an impressive work session. I was really, I was listening in, and it was a wonderful debate. Thank you.
Thank you. So what we have discussed is we're going to discuss the bill. We're going to discuss the amendment that you submitted. We're going to discuss the other amendment that we have in our packets that I know you've seen. We're not going to vote on either today because we're losing members since we're running late, but we will meet again on Thursday, if not before, to make sure to take a vote on this. So, but for now, since we have all the stakeholders here, let's have a discussion. Lisa.
House Bill 652 requires the Office of the Attorney General, in consultation with the Maryland Department of Health and the Maryland Department of Labor, to produce a guidance document concerning the application of employee protection laws to the employment of personal care aides by residential service agencies. The guidance document must be completed by December 30th, 2021, and revised and updated each year. The Secretary of Health must provide the most current version of the guidance document to each licensed RSA. There are amendments on page 5 and 6 of your packet. The amendment on page 5 clarifies that the certification is required as a condition of the initial license and every 3 years thereafter. And the amendment on page 6 does the same thing as the first amendment, but it also strikes the language requiring an RSA to report to MDH on whether it classifies personal care aides as an employer contractor and the hourly pay rate of the personal care aides.
Awesome. So just for the committee's benefit, we have these 2 different amendments. One was brought by the sponsor. The other I put in my name at the request of stakeholders. We just need to discuss sort of if the committee's comfortable with the bill, if it's, we'll do either one or the other amendment. We don't need to do both. And so I guess we should discuss the different amendments as well as the bill. I know there were some questions on the guidance, the specifics of the guidance document. So we have a number of stakeholders here who are welcome. Let's hear from them, I guess. Maybe Dave Rodwin and Dana Kaufman, just briefly, and then if we have questions from the committee about the bill overall, we'll handle those, and then we'll get into the discussion about the reporting and whether we're leaving the reporting in or not. David. Oh, Delegate Chief, do you have anything to add first, since you're here?
First of all, thank you for your thoughtful approach to every bill. I want to just point out some obvious stuff that I wanted to remind you, because I did send an email right before this session, and not sure if all of you have had a chance to quickly review that. I was made aware of the amendment, I think Friday, and then I appreciate the chairwoman's outreach to alert me of that. So I want to say that, first of all, this year's bill has been heavily compromised and has stripped any and all of the provisions related to enforcement. So it was actually based on the MNCHA's position from, so we were very sensitive about that and wanted to come up with a bill that was a good compromise that would provide us the information we need without rushing to judgment about the industry or who is doing what and whatever. But I would say that the amendment number 3, which I emailed you about, which is to take out the reporting requirement, was essentially gut the whole bill, because that's the meat of the bill. I would never want to introduce a bill that only asks the AG to provide a piece of document. I mean, what's the point of that? It's already in the law, you know? So I want you to consider the fact that the bill as written is heavily compromised, is very reasonable and business friendly. And also the bill as written has passed the Senate 45-0. So I would urge you to keep the reporting requirements in, and we can discuss the specifics when, you know, if anyone has specific concerns related to that requirement.
Thank you. Let's hear from David Rodwin. Are you prepared to talk on this? Yeah, good.
Yes, thank you so much. So as Delegate Chi explained, the bill sort of has 2 parts. The one that I think everyone is in agreement on is the guidance document, which is a document that the Office of the Attorney General drafts in consultation with MDH and DOL, just explaining what existing law already requires, doesn't change what existing law requires or impose any new obligations. It just explains what Maryland's employment law already requires and then applies that those requirements specifically to this industry, so that the average RSA owner gets a sort of breakdown of how the law applies to their industry and doesn't need to engage a lawyer to go get it. So it's sort of bringing accurate information right to the RSA owners, which they then certify that they've read. As Delegate Chi mentioned, last year's version of the bill had annual that they would have to sign that they read it every year. This year's version, we've adopted the amendment that's just, once every 3 years. So that's, sort of a compromise out the gate. And then the reporting provisions are, so the whole idea is just operating under the premise that sunlight is the best disinfectant. There's a big problem in this industry with the misclassification of personal care aides as independent contractors. And it's a big problem of why we have this workforce gap. We just don't have enough workers to meet our state's aging population's need for it. And the idea is, well, let's just, have shine a little light on what's going on, not impose any real substantive obligations, but just require that the RSAs report to MDH workers' classification as employee or independent contractor and workers' pay rates. And the pay rate, I think there's been some conversation about that, but really, we've got this workforce gap. The state's been trying to fix it in some ways, but it doesn't know what Medicaid funded workers' pay rates are. And obviously job quality is a big point, a big part of what drives workers to or from an industry. And if we're going to try and have a holistic approach towards improving the industry, sort of step one is the state knowing what workers' sort of job circumstances are. So yeah, so that's the bill. It's just the guidance and the reporting. As Delegate Chi mentioned, there are no enforcement provisions. Last year's bill had a whole part where the various agencies would cooperate to root out any misclassification and would deny licenses or RSA licenses from any agencies that were found to be misclassifying. This year's bill doesn't have any of that. It's really just a first step that is pretty business friendly. As to the frequency of the reporting, they only need to report the information once. And then, if the information changes, if workers' classification or pay rates change, because it just says report workers' classifications and pay rates. It doesn't, it's not anything like certified payroll that happens in the prevailing wage context where you do it every pay period or anything like that. So pretty business friendly. We've had testimony from business owners supporting the full bill, as well as Legislative Black Caucus, OAG, lots of different stakeholders. So we tried anyway to take a business friendly approach to the bill.
Thank you very much. I'm trying to see who else we have on this bill. I know Dana Kaufman is here. Is there anyone else who needs to speak sort of before we get to Dana? Because I know she has some concerns. I'm not seeing any hands up. So Dana, go ahead and let's hear your thoughts on this and which approach we should take.
Thank you. Thank you very much. And just for the record, Dana Kaufman, and I'm here on behalf of the Maryland National Capital Home Care Association. I do want to clarify one point, because we keep hearing that this was a compromise bill, and typically that occurs with two parties. The bill last year was heard on March 10th, which was basically 1 week before the shutdown occurred for COVID. While we appreciate the advocates trying to address those concerns, we did not have any additional conversations on this bill until this bill was introduced. And we did provide information that we had a concern and we would be opposing that reporting. So I just want to make sure that that's clear, because whenever I hear compromise, I don't want anybody to think we're going back on a deal that had been made. So with that point, again, I do want to emphasize that Minka does support the guidance document. During the hearing, it is interesting because during the hearing, it seemed like the impetus was on wanting to educate the business owners, because there are concerns that inadvertently some may be misclassifying because they don't understand the full rules regarding independent contractors and employees. And to that note, I also want to make it very clear that the RSA regulations allow for both models to be used. So it's not like they're somehow using a worker that they're not allowed to use in that classification. So just really wanted to make that point as well. But again, the purpose that we thought the bill was to educate the RSA. So which is why we are in full support of the guidance document, but we are not in support of the reporting, because one, why it is being said that it's supposed to be one time and things along those lines. The language of the bill does not say that. Second of all, this is not being requested by the Maryland Department of Health. So it's very unclear that after this is reported, how this information is actually going to be used, looked at, compiled. That has not been made clear. So that's a concern. It's also interesting that except for those few providers who do cost settlement reports, no other provider is required to give pay rates in Medicaid, their specific pay rate. So that seems to be setting a stage that is different than other Medicaid providers. And again, just the administrative issues. Again, we support the compliance document, but we feel like that should be the first step, and we would like to have the reporting requirement removed from the bill. Thank you.
Thank you. We have questions from committee members. We'll hear from Delegate Saab.
Thank you, Madam Chairman. So I guess, is there an amendment to keep the reporting or to remove the reporting?
So there's two different amendments. Delegate Chi has an amendment in your packet that that does not remove the reporting. It's just another amendment to conform it to the Senate version of the bill. And then there's an amendment in my name for discussion purposes that also does what Dana is asking and removes the reporting.
Okay, so are we going to move any of these amendments, or can I move any of the amendments?
Well, I did promise Delegate Krebs we wouldn't do any votes, but we can discuss the amendments so that members are informed on on their decision for the next time we meet, so we can make a quick vote.
Okay, no, that's fine. I'll wait. I wasn't sure if we're doing it now or not.
No, I appreciate
Thank you.
it. We would be, but I know Delegate Krebs asked so nicely. Delegate Cullison.
Thank you, Madam Chair. So I'm wondering, is there anything in place where the employee is informed of the differences between being an employee or a contractor, and how does one learn about that? And when they go to an RSA to work, is there someone who's explaining to them the difference between the two? Do we have any processes in place for them to for the individual to understand, the employee to understand?
If it's okay, I could try to answer that.
Absolutely.
Thank you so much. No, there is no information provided to the worker. Unfortunately, Maryland's Workplace Fraud Act, which deals with employee misclassification, only applies to construction and landscaping. And I think that's it. But in any event, industries like that are not home care. And that law does require that any employer who is classifying a worker as an independent contractor needs to give a document that the Maryland Department of Labor has put together explaining what it means to be classified as an independent contractor. But unfortunately, that law doesn't apply to this industry. Yeah.
Madam Chair, may I follow up?
Sure.
So if I'm hearing you correctly, David, you're saying a document like this already exists, and it's
Yes.
just not being used in this venue.
That's correct.
Okay, that's helpful. Thank you, Madam Chair. I think it might be something we might want to consider. Because it seems to me those are the folks who need to understand the most about what they're signing up for.
That's a really.
Madam Chair, can I comment real quickly on that? I might have some clarification for Delegate Collison.
Okay.
So typically, first of all, the IRS is pretty clear on classification, who's W-2 and who's 1099. But typically in the normal corporate world, the way it happens, when you get to the interview, all that stuff is discussed when you go to HR, because when you get the offer letter, it would be specified in there how they be treated, and then it would discuss all the benefits. So, I would say 99.9% of companies do it at the time of the hire when they get the offer letters.
Thank you, Delegate Cobb. I see Dana Kaufman raise her hand too, so she may also have an answer to that. Is that why your hand's up, Dana?
Yes, and I was actually, Delegate Saab, I think jumped and not jumped, but kind of said what I was going to say as far as HR. So again, we support the guidance document, and if it helps educate both the workers and the employers, or the organizations, the agencies, but I don't think you can make just a broad statement that just because it's not required in law, that it's not being done. Because again, you still have to file information with the, for tax purposes, your 1099s, your W-2s. So the information is being collected and provided. Thank you.
Does that answer your question, Delegate Coulson, a little more?
It does, and I didn't mean to imply that it wasn't happening. It's just the employees that are coming into the residential care RSAs may not completely understand the differences in a 1099 and again, I don't want to do that imply that across the board either. But the fact that we have this bill in front of us at all means there's a lack of understanding among these institutions around the difference between the two. So that means to me, there's a lack of understanding among the employees.
Thank you, Delegate Clausen. Delegate Bagnall.
Thank you, Madam Chair, and thank you to Delegate Chief for being here today to talk us through this. 30-second dance break. I'm still trying to sort of wrap my head around how these two go together, because I understand the guidance and I understand the concept of sunshine, but I'm not sure if we wouldn't benefit from a broader attempt at having a perspective on the entire industry. And I just don't, does this capture that with that language? Does it capture sort of a perspective of the whole industry, or is, I'm not as familiar with residential versus assisted living versus, senior care. And I think there's a lot of overlap there. So I'm trying to figure out if there is a mechanism by which we could understand what this looks like industry-wide.
It looks like Dana put her hand up for that one. Dana, was that to respond to the question?
Actually, that was my hand still up, but I'm more than happy to try to answer that question.
Okay, sure.
Not really sure the question, but are you asking basically like what is the difference of like what is a residential service agency and the care that they provide over other care settings?
Right. If we're looking at, if we're trying to put some sunshine on pay rate and reimbursements, and how is residential care fit into that whole landscape of senior care?
Okay, so I can try to do that. So residential service agencies are home care. So they hire individuals or contract with individuals to go into a person's home, as opposed to in a facility such as a nursing home or assisted living. Sometimes families and residents will actually contract with a residential service agency for additional services within an assisted living. But for the most part, these are individuals that are contracted with privately by an individual or family members to have care provided in their home. They are different than a home health agency, where a home health agency is Medicare certified and often accompanies a acute care visit, where a home care may be, cueing and coaching, assisting with activities of daily living. It's really depending on which type of staff person is going into the home, whether it's a certified nursing assistant or someone else. So that's kind of how they fit into the continuum. And because the residential service agencies, they can be reimbursed privately or they can be reimbursed through Medicaid if they participate in that program. So hopefully that helps provide some light on that issue.
That did. Thank you. Thank you very much, Madam Chair.
Absolutely. And I saw that Dave Rodwin also put his hand up. So do you want to take a bite at trying to answer that apple as well? And then we'll hear from Delegate Chi, and then Delegate Carr has a question.
Sure. Thank you so much. And if I understood your question, Delegate Bagnall, to be sort of, well, why sort of placing the RSA industry sort of in context, why are we focusing on misclassification with this industry and not in these other industries? And that's because this industry is a lot less regulated than some others, like nursing care. And maybe because of that, this problem of misclassification is much worse in this industry. And it's true, it's not just true in Maryland, it's across the country, depending on how the Medicaid programs operate in each state. But in our observation at the Public Justice Center, especially in the Medicaid funded home care RSA sort of field, this problem of misclassification is the worst. But there isn't unfortunately, any sort of organized data collection because the state doesn't require reporting. And so there isn't any resource we can go to say, okay, well, these percentage of RSAs are classifying their workers independent contractors. And even though the regulations mention classification of workers as employees or contractors, they don't authorize misclassification, of course. I mean, the labor laws are what they are, and you can't have a regulation that sort of goes around that. So they sort of mention that RSAs might, however they classify the worker, they're bound to do X, Y, and Z. But that doesn't authorize them to classify workers as independent contractors. And actually, that's part of the problem. A lot of agencies get a little confused when they see that and think, oh, that means I just have the worker sign a document and that makes them a contractor and that gets us out of labor protections. But there's sort of a lot of confusion around that. And that's part of the need for the guidance and also part of the need for the state to sort of just collect a little basic information from these Medicaid funded RSAs only.
Thank you.
Absolutely. So let's hear from Delegate Chi and then Delegate Carr. Delegate Chi.
Thank you. I just want to respond to Ms. Kaufman's a couple of comments early on. When I said this is a heavily compromised bill, and I mean every little bit of it, because while yes, last year we had an early sine die because of the pandemic, we heard loud and clear her opposition, her position, her association's position to that, and we took that to heart. That's why, early on this year, we reached out before this bill was drafted and was introduced. So it was because of her position that we redrafted the bill, taking into consideration the sensitivity of these home care agencies. And, as I said during the hearing, we don't want to be presumptuous about why people do certain things or don't do certain things, or their level of awareness or their willingness to comply if we share with them the expectations. This is a very basic expectation to say, let us, first share with you the expectation and let us give you some time to make self-corrections if necessary. And also let us understand the prevalence of industry practices. And maybe these days with the gig economy popularity, people want to be hired as contractors for flexibility working across several home care agencies. And maybe there is a reason for companies doing certain things the way they want to do. We don't want to be judgmental without collecting information. That's all we are doing. So I want to be very clear about the intent of this bill without being put into certain buckets to say we're trying to go after this and that. So I think if you want to see a compromise bill, this is basically it. And it's very reasonable. And as far as what Ms. Kaufman said, how the information might be used or misused, I have to say that we did take the time to look into the codes in Maryland in terms of Public Information Act. The kind of wage information and classification information, especially when it comes to wage information, which is codified as financial and commercial information, is protected from PIA. So you would not be subject to Public Information Act, even if people are going to go after that and request it. So I just want to put that to rest. Okay, thank you.
Thank you, Delegate Carr.
Thank you, Madam Chair. So I'm actually fine with the bill as it passed out of the Senate. I would be happy to vote for that. I can sort of understand the argument about, not wanting to reveal information about wages, but I do not understand the resistance to reporting about, the extent to which the employees are employees versus contractors.
Did you have a question at the end of that or just a statement?
I guess that's a statement.
It's a statement. No, it's good. I mean, the committee's going to have to make sense as to which amendment to move with. So we can move to that discussion, but I want to just make sure the committee knows we're going to vote on it when Delegate Krebs, we also lost Delegate Cullen, I think a couple other members. So I know that Delegate Krebs in particular had a lot to say on this bill. So that's why we held it for her. So I guess unless there's no more question, I see more. No, that's Delegate Carr and Delegate Chi. So we're good. I see no more hands up. So we can pick up this conversation. Eric, go ahead, Eric.
I just want to say, chime in with one comment, which is thank you to all involved. There is, as everyone agrees, a workforce crisis. As our senior population ages, there are not enough workers to help them. And this has been a really thoughtful discussion. We're appreciative of Minka for their work on the State Alzheimer's Commission and working with us on the dementia training legislation that this subcommittee worked through earlier. One thing I did just want to emphasize is a little bit about who the home care workforce is in Maryland. And there was a report conducted on this. They are 88% female, according to a 2018 work report by PHI International. They are 61% Black. 75% of them do not have a college degree, and 46% of them rely on public assistance. Median personal earnings, according to that report, were $20,152. So there are a lot of things to work through on this legislation. I do know the bill has been revised from past years, and I think it's a thoughtful approach that the committee will wait until hearing from all members next week to vote on it. But big picture, it's great that we're working through again and continuing to think about the senior workforce and how we can improve the situation.
Thank you. Okay, so and just for clarification, we will come back on Thursday of this week at our regular meeting time. So this will be the top of our agenda on Thursday. We do have a bunch of other bills that are coming to the subcommittee. So we'll have a busy meeting on Thursday, but sorry, we can't vote on this today, but we will come back to this. Anybody else have anything to add? I'm just looking for any hands raised. Otherwise, we'll.
I think Dr. Mark Bay might be a good resource.
I see him, but I don't see his hand up. Did you have something to add, sir?
Yes, I did. Thank you for letting me just, I can just speak from someone that's had an RSA for over 33 years. You know, I check with my, first of all, I would have no problem reporting on my classifications because I classify everyone as W-2 employees and their rates because, you know, I believe that, you know, we pay the maximum we can getting Medicaid reimbursement. So I also check with my billing department, ask them, you know, would this be a burden for them to put this data together and report that? And they said, absolutely not. So that's just from, you know, our perspective. I just want to share that.
Thank you. It's very helpful to have information from on the ground. Anyone else with anything to add? Otherwise, we will conclude the meeting and take this up again at the top of our next meeting. Okay, with that, we're going to adjourn. Thank